Good day, friends, and a warm welcome to the 33rd episode of 4D, that is detailed discussion and dialogues for Indian diabetics. Today, we have an expert speaker with us, Dr. Akash Panigrahi from the Tata Hospital in Jamshedpur, and he'll be speaking to us about diabetes and Ramadan. This is the holy month of Ramadan going on, and we need to learn how to manage people, believers who are fasting. So, warm welcome, Dr. Akash.
Yeah, good evening, everyone. I am Dr. Akash Panigrahi, consultant endocrinologist and diabetologist at Tata Main Hospital, Jamshedpur. And today we will be discussing Ramadan and diabetes. What are the challenges ahead and how to manage and complete the Ramadan fasting safely. Please add the slides. Yeah. So coming to uh, the diabetes, we know that India is in India we have the second highest number of diabetes in the world, and we are just behind China. And 1 in 11 adults is living with diabetes in India, and sadly, half of them are actually undiagnosed. And 40 million people in India are actually living with impaired glucose tolerance, which place them at high risk of developing type 2 diabetes. And this rise in number of type 2 diabetes in India is actually driven by a complex interplay of socio-economic, demographic, environmental, and various genetic factors. Now, we all know that Ramadan has started. It is a holy month for all our Muslim friends. And during Ramadan, it is mandatory by Islam that all healthy adult who has reached, all healthy individual who has reached puberty, actually it is obligatory for them to maintain a daytime fast from dawn to dusk. The duration of which is actually varies between 12 to 16 hours a day. And during that period, fluid and diet both are not supposed to be taken. So during this period, there are marked changes in people's diet. There is erratic eating pattern. The daily fasting and feasting cycle is there. The sleep is altered. The exercise regimen is altered. So all these alteration at the onset of Ramadan may actually hurt the glycemic level of our individual. So in the end, for a person with diabetes, there are lots of challenges, and we need to know whether celebrating Ramadan comes at a price for good health. And management of diabetes during this phase become extremely important. So if you see the continuous glucose monitoring graphs for patient during fasting and during non-fasting period, we can see that during Ramadan there is lot of glycemic fluctuation. So at the just 3 to 4 hours before iftar, there is a prone for hypoglycemia. There is a propensity for hypoglycemia, and after iftar there is large glycemic fluctuation when the patient went into hyperglycemia. So glycemic variability with chances of both hypoglycemia and hyperglycemia are very high during this Ramadan period. Now, if you see the physiology of fasting in a healthy individual, now during the feeding stage, the glucose, when we take food, the glucose in our blood increases that stimulate insulin secretion. Now, the insulin inhibit the gluconeogenesis from liver and kidney and stimulate the glucose deposition in muscle as glycogen reserve, that is glycogenolysis. Whereas during fasting stage, because there is no insulin and the counter regulatory hormones, that is glucagon, are elevated, they stimulate gluconeogenesis from liver and they deplete the glycogen from liver and muscle, uh, thereby maintaining the fasting glucose level in our body. Now, but in a patient with diabetes, the things are little different. In their body, insulin secretion is either decreased or absent, and there is also insulin resistance. So during a fasting stage, the gluconeogenesis and particularly in type 1 diabetes, the ketogenesis are increased during this prolonged fasting. Also, the glycogen stores are depleted due to excessive breakdown. So the glycogen stored in our liver typically lasts for 10 to 12 hours. And after that, ketogenesis starts, and these ketone bodies are utilized by our body, whereas glucose is utilized by brain and other important tissues. So, for a patient with diabetes who is observing a Ramadan fast, which is a prolonged fast, there are many risks. The risk of hypoglycemia, hyperglycemia, diabetic ketoacidosis, also dehydration and thrombosis are there. So, the challenges are many for a patient with diabetes. Also, taking insulin or other oral anti-diabetic drugs without any dose adjustment during fasting increases the risk of complications. Also, during fasting, the physical and mental alterations are there, particularly for elderly and comorbid patients. The complications can skyrocket. So, due to all these things, a diabetic patients before observing the Ramadan fast, they should be educated. They need a pre-Ramadan assessment. Uh, if we see the gravity of this problem, this APDR study, which is a retrospective population-based study done in 13 countries, and which has analyzed data from around 12,000 patients, they have seen that around 40% of our type 1 diabetes patients and around 80% of type 2 diabetes patients actually they observe Ramadan fast for more than 15 days during Ramadan. The physical activity, sleep duration, food intake, fluid intake, sugar intake are actually unchanged in half of the patients. Even doses, including insulin doses, are not changed in majority of patients. And if we have a look at the risk of complication, we can see both severe hypoglycemia and hyperglycemia risk are increased many-fold during Ramadan than when compared to before Ramadan period. So during Ramadan period, the risk of diabetic complications are increasing by many fold. So they need a pre-Ramadan assessment and a risk stratification, preferably 6 to 8 weeks before Ramadan, where they will be analyzed, a full annual review, detection of screening for diabetic complication, measurement of their HbA1c, blood pressure, lipid, uh, their doses, diet, and exercise need to be optimized, and they need to be educated. Not only the patient, but the whole family need to be educated regarding the signs and symptoms of hypoglycemia and hyperglycemia, the planning of meals, the importance of blood glucose monitoring, the changes in medication, and management of acute complications. And they should be specifically uh, taught how when to break the fast. Now, this was the risk stratification system from IDF-DR guidelines, which are the old guidelines where we used to stratify patients by the three-tier traffic signal system, where the patients were categorized into very high risk, and moderate or low risk. But now we have uh, changed that, and nowadays we are using a highly customized, individualized calculator, where every individual will be given a score based on the his or her risk assessment, that is the diabetes type and duration, presence of hypoglycemia, characteristics of glycemic control, SMBG frequency, uh, the pregnancy, the frailty and cognitive functions, physical level, their previous Ramadan experience, the duration of fasting. And based upon all this, they will be classified into low risk, moderate risk, and high risk. Those in the high risk category, they must not fast. Those in the moderate risk category, they should not fast. And those in low risk, actually, they can fast safely with some education. So during this pre-Ramadan assessment, after risk quantification, we should give Ramadan-focused education to the patient and the family, which will encompass the blood glucose monitoring, the fluid and dietary advice, exercise advice, their medication adjustment, and as I have already discussed, when to break the fast. Now, SMBG frequency, monitoring your blood sugar is very important. Now, we should re-emphasize that monitoring blood glucose does not invalidate the fast. Your fast is not breaking. So we should monitor our blood glucose, and that should also be individualized. Somebody who is on a stable doses of medication, maybe once or twice a day, maybe before iftar and 2 hours after iftar, blood sugar monitoring is important. For somebody who is on insulin, a more frequent SMBG monitoring is required. And they also need modification in their diet. Particularly, we should not exceed our calorie target, and that calorie should be divided between iftar, uh, sahari, and any dinner if the patient is taking, and complex carbohydrate, mainly the whole grains, lots of vegetables, fruits that should be taken. Protein intake, we should take optimum amount of protein. Uh, High fat diet, sugary beverages, especially the drinks, high sugar drinks should be avoided, and fried snacks should also be avoided. Now, coming to physical activity, normal level of physical activity is encouraged. excessive vigorous exercise is actually detrimental because that can precipitate hypoglycemia and dehydration. The Tarawih prayer that is part of Ramadan is actually a moderate intensity exercise, and that should be encouraged. Now, for diet, we can follow the Ramadan plate. That is very simple to follow. That our fruits and vegetables should constitute around 50% of our plate. We should take whole grains and protein. One glass of low-fat milk or buttermilk, one or two dates, and in the dessert we should choose the healthy veget options like a small piece of fruit, and we should use less oil. So Ramadan plate is something that is very easy to use and should be encouraged. And coming to the treatment strategies, actually, patient should be evaluated 6 to 8 weeks before so that we can stabilize their medication doses. New medications should not be initiated during Ramadan. So, and patients should ideally be on medications that have low risk of hypoglycemia, like metformin, the DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 RS. We are particularly concerned about the sulfonylurea and insulin doses. Now, they need some modification, and that should be individualized actually. So many a times the sulfonylurea doses we reduce for those who are on well controlled on diabetes. Sulfonylurea doses we reduce or shift the time to iftar. Insulin doses also we modify, individualize. So that should be done beforehand. And if you see the flow chart, the patient should contact the healthcare provider 6 to 8 weeks before. Risk should be stratified, and patients should be advised accordingly. All patients should be given structured education regarding their risk, role of SMBG, advice regarding when to break the fast, when to exercise, the diet and fluid planning, and the medication adjustment. So we want our patient to observe Ramadan safely, and the patient should understand that we as a doctor, we are on their side actually. We want them to observe the Ramadan because their spiritual and social health is also important as their medical health. So we wish all our patients a happy and safe Ramadan. Thank you.
Thank you, Dr. Akash, for that wonderful presentation. Many questions coming in from the audience now. And the first question is, how frequently do patients come and initiate a Ramadan conversation before Ramadan? Does the patient usually do it in your practice, or do you have to initiate the conversation?
Yeah, sir, very nice question, sir. Uh, sir, if I see my place of practice, means I have practiced at Kolkata and now in Jamshedpur. So around when Ramadan is around the corner, people generally they initiate this talk themselves, and the vast majority of our patients actually initiate this themselves actually. And sometimes I also initiate the talk. I ask them actually whether they are going to fast or not. So most of the times, many of them are just means no, the sugars are not controlled. We will not be fasting, and many are just affirmative. Yes, I will be fasting. So the patients are actually concerned, sir, regarding
Yeah.
the Ramadan and how to manage their diabetes in Ramadan. They are concerned with this.
Many times patients are shy also. They may feel afraid. What will the doctor think of me if I talk about fasting? At other times, they are just not aware that this is part of a diabetes practice, that we have to take care of the patient. So, before Ramadan, the month is called Shaban, and before that, Rajab. So, I think when Rajab starts, we should begin speaking with our patients. Even if a particular
Yes,
patient says, I do not want to fast, thank you for asking, I don't want to fast. Maybe, you know what she will do? She will bring her sister or sister in law, and you will be able to help those patients.
yes, sir.
So,
Rightly pointed out, sir.
and she may not come this year, but next year she will come back and she will say, yes, you had asked me 12 months ago, and now here I am. Now I want to fast this time. So please help me.
Yes,
Another question coming from the audience is, can everyone fast during Ramadan, or are there people who are at a relatively higher risk of complications?
yeah. Sir, if you see the practical reality, vast majority of our patients will actually fast, and some will fast even against medical advice. So that is the practical reality. Now, if you see, sir, we need to actually individualize our patients. Now, somebody who had been recently diagnosed with diabetes, the blood sugars are uncontrolled. Versus if I consider a patient who is diabetic for last maybe 8 years on a stable doses of medication, He had already completed Ramadan fasting successfully for last few years. So both are not same. Similarly, somebody with lots of complications, be it microvascular or macrovascular complications, they are not the same. So we need to individualize our patients, and in this regard, all the international guidelines, they are very clear. Now, as the time has evolved, the guidelines are also evolving. For the three-tier traffic light system, we now are using the very highly customized or highly individualized risk calculator, that I would say. So we need to take into account our patient's risk, all the diabetic factors like the type of diabetes, their duration, what medications they are taking, what is their hypoglycemia risk, their complications, their family or social support system, their previous Ramadan experience, that is very, very important, and what is the duration of fast they are planning. So, after taking into account all those things, by using the calculator, we will see the risk of our individual patient and we will individualize themselves. Those who are falling at high risk or moderate risk, we will either advise them not to fast, and those who are in the low risk, they can fast with obviously some education to do that safely.
Right. Uh, are there people in your practice where you feel the risk is very high, the biomedical risk is high, but then health is defined as a composite of not only physical but also emotional and social well-being, mental well-being,
Yes,
and the
yes,
patient says, Daksa, for me spiritual health is paramount. I want to try. I want to fast. Then
yes.
how would you counsel your patient and what safeguards would you put in place?
Uh, Sir, first of all, as you pointed out, obviously the spiritual health and social health is also very important. We need to respect the feeling and decision of our patients actually. So even if somebody is high risk or very high risk, if he or she so desires, then actually we should accept that and counsel them accordingly. So we should provide them the education so that they can minimize their risk actually. If somebody is educated, so education is a very powerful tool. So if somebody is educated, he or she can do that thing uh, meticulously. So in the pre-Ramadan counseling or in, even those patients who are coming little late, so we should give them the Ramadan focused education itself. That means we should counsel them what are the risks, particularly risk of hypoglycemia, hyperglycemia, diabetic ketoacidosis, dehydration. So uh, they should be knowing this, that these are the risks. We should counsel them to monitor their blood sugar uh, regularly. When we should re-emphasize that monitoring blood sugar will not invalidate the fast, uh, and provide them education regarding their fluid intake, making good dietary choices, be it at Sahri or at iftar, monitoring their blood sugars regularly, and they should be educated regarding when to break the fast. Actually, that is very important, and not only the patient, actually the whole family actually should be educated regarding the symptoms of hypo and hyperglycemia at least, and the indications where to break the fast, when to monitor, how to monitor. If our patients and families following these things, they even though they are high risk, they can majority of them can actually complete the fast successfully and safely actually.
So, very important points coming out from Dr. Akash's explanation. You have to empower the patient and the family and caregivers. It's not only family at home. Supposing the person is working in a professional setup, then fellow co workers, they should be empowered. How do
Yes,
you empower? Stepwise, if we talk about it, first of all, pharmacological optimization that is to be done by the doctor. You reduce the dose of insulin, you reduce the dose of sulfonylureas, like Dr. Akash has explained to us. That's pharmacological. Second is nutritional optimization. You ensure that at the time of Sehri, there is adequate complex carbohydrate and adequate protein, which gets broken down slowly throughout the day to give you a reserve of calories for the 12 or 14 hours of fasting. Don't stick only to simple carbohydrates, otherwise, you will feel very hungry after 4 or 5 hours. In nutritional optimization, it's not just about food. We spoke of food, of complex carbs and proteins. You also look at the beverages. If you take a beverage that is very rich in sugar or very rich in salt, you are bound to feel thirsty after 3 or 4 hours. So whatever salty beverage you wish to take, maybe chaj or salty buttermilk, that we can take after iftar before going to bed. But if you're taking a beverage at breakfast time at sehri, then we would be best served with water or maybe lemonade with minimal salt or maybe with buttermilk or milk without any salt. This will make you less thirsty. So, first of all, was pharmacological optimization. Second is nutritional optimization, both beverages and foods separately. Another way in which you empower your patient is hypoglycemia awareness training. So, make your patient aware of the symptoms of hypoglycemia. And then SMBG, teach the patient how to do SMBG. And Dr. Akash, earlier there was this, especially amongst my elder patients, there was this issue that checking a glucose breaks the fast. Is that correct?
Actually, sir, that was a we can say that was a myth we can say nowadays. Mostly the elderly people, because although young generations are they are pretty much sure that this does not invalidate the fast. So checking a SMBG will not invalidate the fast. That we should tell our patients means upfront actually. And even the continuous glucose monitoring, if somebody is okay with that, that's a very good choice, especially during Ramadan period. So that is saying.
So these are good things, and there are fatwas from the leading ulema of the world that you should check glucose because your paramount duty is to take care of your body, which is a gift from God.
Yes, sir.
Two more things we can do to strengthen our patients to protect them against risk. So we talked of hypoglycemia awareness therapy and of glucose monitoring, but the best is a practical experience. So many of our patients on the 15th, 16th, 17th day of Shaban, which is the month prior to Ramzan, people practice. They do a practice fast. So they see how long they can work, and maybe earlier patient was on a particular dose of glimepiride glycoside. They reduce it, like Dr. Akash has taught us, and then they check, how things go on. So you don't feel spiritually bad also if you break the fast, and it tells you what kind of dosage to take or how much of food to take at Sehri. The last optimization is regarding profession. Let us say your patient is a bus driver, maybe
Yes,
an air traffic controller, where split decisions are required in split seconds. And in hypoglycemia, we all know the nerves can become a bit slow. Then in such a case, safety would mean that maybe the patient takes an off from that kind of work, or if the patient is a driver, he can limit his professional work to maybe 4 hours after sehri. So let's say up till 12 noon or up till 11 a.m. he can work, and after that maybe he can take an off if he really wants to fast. So that would be a personal call, but these are ways in which we can equip our patients to fast in a safe and meaningful manner.
yes, sir. Rightly pointed out, sir. Very pertinent.
One last question, Dr. Akash, coming up. Of course, you've explained the nuances of dose modification for the various drugs. The question that is coming up is we have focused on glucose control, hypo and hyperglycemia. What are the other complications that may occur in Ramzan, and how do we protect ourselves against them?
Uh, Sir, one major thing, because mostly summer is around the corner, means it's getting hotter. So and also not only food, actually drinks are also prohibited between during this fasting period. So dehydration, particularly in elderly, those with renal impairment, those of our patients who are prone to hypotension. So dehydration is another thing, sir, that we should focus. And if a patient is on some kind of drug like SGLT2 inhibitor, then that is also more important. So dehydration is something that we should also focus on, sir. Not only our glucose control, but dehydration and dyselectrolytemia, that is also is of concern.
That's very important. And like we said, you can counsel your patients to increase their fluid and electrolyte intake after iftar so that they can build up reserves for the next day.
Yes, sir.
Dr. Dr. Akash, it's been great having you with us, and the way you explained things in such a simple manner. I'm actually reminded of a quote from the Charak Samhita. Uh, Vimasthanam is the name of the book, and what they say is that when an expert teacher comes on stage, he spreads light and he dispels the ignorance of darkness. So, listening to you, that is what I felt. Thank you for having taught us all this, and thank you for helping us help our patients. If we are able to help believers fast successfully in a meaningful manner, in a spiritually meaningful manner, and in a safe manner, I think we will have earned a lot of merit, you and I.
Yes, sir. Sir, actually, patients would feel that we as a doctor are on their side. Actually, many a times they feel that we will just ask them not to fast, we will prohibit, we will restrict. So patients should know that we are on their side. We want them to complete the fast, just that we want them to do that in a little safer way, so
Safe
that they
manner.
can complete that and they can avoid any devastating complications. Actually, so this is something our patient should know, that the doctor is actually is in his or her team and is playing alongside him or her.
So,
It was
very
nice
well.
talking to you, sir.
Yeah, thank you. Very well said. And we'll remember these words as we all go back to our practices and speak with our patients, converse with them. Thank you, Dr. Akash, for having helped us and for having actually spread light, for having spread knowledge. The Arabic word is ilm. So thank you for having spread ilm, and thank you for dispelling the darkness of ignorance. Thank you, everyone, and Jai Hind.
Thank you, sir. I also learned a lot. Thank you, sir.
Do remember to log into the next episode of 4D. We'll have another topic related to diabetes, and we'll continue this conversation, this journey towards better healthcare for our country. Jai Hind once again.